So is everybody Plavix out yet? Practically. What is new with Plavix? So I found there actually is some interesting stuff that is new with Plavix. And the first part I found actually is that there's a lot to how Plavix is actually taken in, metabolized, and how it works. Number one, besides the pharmacy people, who knew that Plavix was a prodrug? Okay, 2, fine. 2 out of how many? Not very many. So there are, what it comes down to is that there are just a whole lot of enzymes and proteins that are actually at play in getting Plavix from your mouth to where it actually starts to work down here at the platelet. Is that too bright? Can you still see it? Okay. So the deal is, that in the parentheses here, the tiny parentheses that are hard to read, are basically the genes that are all at play. There's a gene clear up here at the very top that helps with intestinal absorption, because without this particular gene, it doesn't get absorbed properly. If it doesn't get absorbed, and actually even in the best case scenario, about 85% of Plavix is actually esterified, shunted down the rest of the gut, and never actually gets absorbed, so that the oral bioavailability is very small. But saying that it does get absorbed, this gene is working properly. Next is that this prodrug has to be converted to an active metabolite to actually function. A whole bunch of P450 all in the CYP system. P450 hepatic enzymes that are actually responsible not for degrading, but actually for, in essence, metabolizing to where it's actually functional. So then finally, you get down here to active metabolites. Only about 15% of the drug that's taken in becomes an active metabolite. And then it comes down to its receptor here on the platelet. And if you remember, it blocks basically ADP activation of the platelet. When ADP activates the platelet squirts out little 2B3A receptors, and that's what helps with platelet cross-linking. And there are antibodies that you can put onto this receptor as well so that the cross-linking doesn't occur. But the point is there are a whole bunch of different steps, and it'll be important in just a second, that are all important in getting Plavix from the mouth all the way down here to where it's actually functional and deactivating platelets, or preventing platelet activation. So there are a number of studies to cover here. This was one that just looked at genetic determinants of the response to clopidogrel or Plavix. And if it's okay, I'm going to use those interchangeably. This one looked in, this was actually a French study, 2,200 patients presenting with acute MI and also receiving Plavix. And followed these people out for the course of a year and looked at risk of death from any cause, including non-fatal stroke or MI during 1 year of follow-up. In essence, what they did is said, here's the cause of death, and we want to compare this to people with various gene variations of these alleles, the one that's involved in absorption, the couple that are involved in metabolic activation, and then the biologic activity, including the receptor and the one that helps promote the receptor getting up to the surface. So, what was found? In this case, patients carrying any two of the CYP, this is the 2C19, which you've all heard of, and then the P450 jumble that's in our head. 2C19, one of the P450 enzymes in the CYP system. People who had 2 loss of function alleles, this is the one that metabolizes the drug from inactive to active form, had a higher event rate. Again, that was death, MI, back up and see, any cause, death of any cause, non-fatal stroke, or MI. So the people with 2 loss of function alleles had a higher event rate compared to people who had no loss of function alleles, or normal functioning. Hazard ratio actually was nearly 2, meaning you're almost twice as likely to have one of these adverse events over the course of a year, just if you've got some loss of function alleles. Among patients who underwent percutaneous coronary intervention, or PCI, the rate of cardiovascular events in those people was actually 3.5 times that of the folks who didn't have any loss of function alleles. So fairly significant. If you have a PCI, you get a stent placed, and you say, gosh, you don't really know if you have these loss of function alleles, but if you do, and you have 2 of them, you're kind of hosed, because you're 3.5 times more likely to have an adverse event, another heart attack, a stroke, or dying over the course of the next year. That kind of stinks. Same studies, and then looked at people who have 2 variants of the ABCB1. That was the one that's involved in intestinal absorption of the drug. If they had that, those 2 variant alleles, compared to people without, 15.5% risk of another adverse event or another event versus 10.5. So the hazard ratio there is 1.72. If you happen to be so incredibly unlucky to have both, loss of function alleles are the one that metabolizes the drug to the active form, and loss of function alleles for the one that helps with absorption. So not only are you not absorbing the drug, it all gets shunted down the gut, but the little bit that you do absorb doesn't actually get metabolized to an active form. Those people obviously had the highest event rate. Up here, hazard ratio is 5.3. So saying you're 5 times more likely just over the course of a year to have another heart attack, a stroke, or dying. Pretty significant. Another study here, and this was actually broken into two parts. The first part of the study, they said that they had a hypothesis that if you had loss of functional alleles, that it may interfere with the metabolism and the function of the drug. So they only looked at 162 people to really determine that. They don't think it was anything earth-shattering here. But they found that people who had at least one of the 2C19 loss of functional alleles or reduced functional alleles had a relative reduction of 32% in plasma exposure to the active drug, meaning that there was less active drug in the plasma. Also a 9% absolute difference in maximal platelet aggregation. The idea with using Plavix is you want to decrease platelet aggregation. So there's a relative reduction of effect of about 25%. So this is all disease-oriented evidence. This is not really patient-oriented. But the point was that they wanted to prove their hypothesis that if you have loss of functional alleles, then it can somehow alter the pharmacokinetics and the pharmacologic response to the drug. And then they did some disease. Oh, sorry, before I did that. This actually looks, I'll back up a second. The pharmacokinetic response was, in essence, the area under the curve, the plasma, the time plasma curve is the best way to interpret this. It was kind of puzzling. What it says is that the two genes actually that were most significant, the very top is the 2C19. There was also another, the 2B6 allele was important in metabolism. Those are the ones that actually you saw less area under the curve is how to interpret this. The response to the left is basically less platelet activation. Again, if you have these two genes tagged, you saw less platelet activation compared to the others. And interestingly, this 3A5 actually, if you had loss of function with that, it seems that the drug seemed to work a little bit better. So go figure there. But they didn't really comment on that particular one. Interestingly also, the 2C19 is not really an all or nothing type gene. There's actually a way that you can code that out a little more extensively to say, well, the gene doesn't work or it does work. Actually, it's kind of a graded effect. You can actually classify people as ultra-rapid genes, meaning that they're very, very efficient. They work really well, and have extensive, intermediate, and poor. The top one here is, in essence, the area under the plasma curve. It was very complicated trying to figure out what all these different bars and lines and stuff meant, and so to be honest, I'm not even going to address it. But the point was that the area under the curve decreased if you were a poor metabolizer, is really what it came down to. And then this one also says, this is looking at reduction of platelet activation, saying you saw quite a bit of platelet activation if you had the ultra-fast gene, you metabolized the drug very well. It came down here to the poor metabolizing folks who didn't do a very good job of breaking it into an active drug. Those people really didn't get much decrease in platelet activation, which is really what we want from the drug.